Hi, all. On behalf of David O. and Tina Hartman, I wanted to reach out to you and provide some information ahead of our in-person strategic advisory group meeting this coming June 22nd in Seattle. We're looking forward to seeing you all here. We're going to be engaging you in some discussion about our projects and findings to date and implications for uh, projects and studies that we have starting up soon, and then plans for what we want to do with the remaining 2.5 years roughly of our current grant to put us in the best position to have an impact and to put us in the best position to compete for a successful renewal. We had originally four projects in our query program. Discuss COPD, which is de-implementing inhaled corticosteroids for patients with mild COPD. David O leads that. Diamond, which is de-implementing antipsychotics to manage disruptive behavior in patients with dementia in VA nursing homes called community living centers. Tina Hartman leads that one. We had a pilot project to reduce inappropriate follow-up of incidental lung nodules that showed up on non-cancer chest CTs, led by Steve Zelliot. And then originally we had proposed a second pilot led by David Winchester in Gainesville to reduce inappropriate myocardial perfusion imaging. That was not funded by our study, but David got support to do it locally and completed that project. We've also, since our original grant, we've helped launch a number of successful grant competitions, all within the VA. There is a VA merit review, the equivalent of an RO1, that's starting up to de-implement supplemental oxygen for patients. It provides no benefit and is costly and increases risk of fires. Laura Feemster is leading that one. There's a VA Patient Safety Center of Inquiry to reduce risky opioid prescriptions. Being led by Emily Williams and Eric Hawkins at VA Puget Sound. There is a study being run out of Ann Arbor by Samir Saini to de-implement proton pump inhibitors, inappropriate prescription of long-term proton pump inhibitors that we supported and helped him in submitting it. And finally, David Winchester parlayed his work on appropriate cardiac imaging into a CDA that we're supporting. So I'd like to provide you with some updates on our original projects and some key findings that we think are going to be important as we develop projects going forward, including wanting to think about how those findings might inform these new sets of grants that we've helped support, helped launch that are starting up. Just to remind you, across our projects, we are studying a similar set of factors at the provider level based on the dual process model of cognition out of cognitive psychology and behavioral economics. What we want to do is understand when we are developing de-implementation strategies that engage providers' reflective cognition, that's their critical thinking cognition, effortful cognition that's slow, but it offers the opportunity to self-correct. And so we see one set of strategies we're employing as addressing reflective cognition through a process of unlearning, exposing providers to new evidence, helping them engage in a critical assessment of that new evidence relative to the ineffective practice, which then hopefully leads to an intention to change something we're measuring, and then leads to a reduction of the ineffective practice. Um, we think that there's the potential for unintended consequences for reactance, a state of anger and negative cognition, basically arguing against the information that's being presented. And this emerges when people feel like their freedoms are being infringed upon. So to the extent that providers feel like we are infringing on their prerogative as clinicians, we might engender psychological reactance. And so that's something that we're very concerned about, and again, measuring. And then we're also concerned about the potential for burnout. That providers, we know there's an epidemic of burnout among clinicians, physicians, and nurses. And the extent to which efforts to de-implement medical overuse is perceived as questioning their competency as providers, we might engender burnout. So again, something we're concerned about and measuring. Um, so the other type of cognition is automatic cognition, and this is behavior and decision making that's driven by ingrained heuristics that develop over time and are extremely efficient, fast, and don't require much cognitive capabilities or cognitive resources. Automatic cognition, these heuristics are cued by something in the environment or a feeling, and we think that there's the potential to develop de-implementation strategies that take into account when those cues emerge, and to introduce a substitute practice, some other alternative practice based on a new heuristic that gets associated with that cue, again leading to a reduction in the use of the ineffective practice. In Discuss COPD, the project to de-implement inhaled corticosteroids for patients with mild COPD, the de-implementation strategy is a proactive e-consult by a specialty care team. The pulmonary team, the specialty care team, based at a medical center, reaches out to providers at outlying community-based outpatient clinics, and they identify patients who have a diagnosis of COPD, are on an inhaled corticosteroid, and have an upcoming visit. They proactively scan that patient's chart to determine if there's an indication for the patient to be on the inhaled corticosteroid, and if not, they enter an unsigned note or unsigned order recommending that the patient be taken off of the inhaled corticosteroid or titrated down, and they provide that in the form of an unsigned order. They also might make other recommendations to improve quality of care, including obtaining a pulmonary function test to confirm that the patient actually has COPD, or placing the patient on other more appropriate medications such as long-acting agents. The project uses a high-quality design, a randomized design to ensure rigor, and it adopts this population health approach, specialist-led population health approach that could be a model for other conditions. And finally, this de-implementation strategy actually incorporates both an unlearning approach and a substitution approach, as I'll explain in a second. The unsigned order looks like this. It explains that it's part of a quality improvement project. It's right there. This is what pops up for the project. The unsigned order includes recommendations for the changes in care, and it provides a rationale for those changes. In this way, it provides an opportunity for unlearning, explaining why the recommendations are being made. It also includes links to trial and guideline information, again, providing an opportunity for unlearning. At the same time, the orders to be acted on, the primary care provider simply needs to sign them. So it's something that they can do rapidly without internalizing this information. And in that sense, it's a substitution. It's something that pops up that they can act on very quickly during a visit, and provides an alternative to continuing that prescription. And I'll just point out too that the order is signed by the specialist, in this case Dr. O. So it's an authority that the primary care provider is likely to recognize. The next project is de-implementing antipsychotics in community living centers, or those are VA nursing homes. The goal is to reduce use of antipsychotics for managing behavioral and psychological symptoms of dementia, so agitation, aggression, etc. The study is testing two strategies, an unlearning strategy and a substitution strategy. So whereas Discuss COPD combined those two approaches in a single de-implementation strategy, the proactive e-consult, in this case they're divided. There is an unlearning strategy that is academic detailing targeted at the prescribing providers, so the ones who are actually writing the prescriptions for the antipsychotics, and then a substitution intervention. In this case, we're using a tool called the QUERI Advisor, which is an online tool containing a protocol called DICE, Describe, Investigate, Create, and Evaluate, which basically just leads frontline clinicians, nursing assistants, through steps to identify the underlying reasons for the symptoms. It could be pain, it could be something's changed in the environment, and it leads them through a set of solutions to address those underlying causes of the behavior. Like Discuss COPD, Diamond uses a stepped wedge design, and we are testing the prescription rate, antipsychotic prescribing rates at these CLCs over time. We're using a facilitation approach to implement the QUERI Advisor tool, and we're doing interviews with caretakers to understand their perspectives when patients are taken off of an antipsychotic. Currently, we're concluding the intervention at the pilot site. That'll conclude in August. We've started at 2 additional sites and are finalizing participation with a 4th community living center, and are hoping to start sometime this summer or early fall. Currently, we've completed baseline surveys at the pilot site with prescribing and non-prescribing providers, the frontline nursing staff, and we've conducted interviews with 5 providers, and are currently recruiting additional provider interviews. The Lung Nodules Project was a pilot study led by Steve Zelliot and Julie Takasugi. The Lung Nodule Project was a pilot study at VA Puget Sound, and it involved an audit and feedback intervention to radiologists about the new Fleischner criteria, which are criteria for evaluating incidental lung nodules and appropriate follow-up. The intervention included a self-study tool, a set of slides of lung nodules, then with an explanation for what the appropriate follow-up would be per the Fleischner criteria. That way a radiologist could view the slides, think about what recommendation they would make, and then have the Fleischner criteria explained for that nodule. This is something, that sort of immediate feedback is something that research in cognitive psychology suggests is very helpful for improving performance. And then the team conducted a pre-post assessment. They did a chart review of patients with incidental nodule findings before and after the audit and feedback intervention. So we'd like to share some key findings from the studies. First, starting off just with the basic findings from Discuss COPD and the Lung Nodule Pilot Project, which are the ones that we've got some findings for on de-implementation. And then some of the mixed methods findings, primarily from Discuss COPD, that we think might inform the studies that we're launching now, maybe also our studies that are in progress, Discuss COPD and Diamond, but most importantly, perhaps, might inform the kind of work that we want to do going forward, and that's really where we want to engage you, our strategic advisory group members. In terms of findings so far from the Discuss COPD project in de-implementing inhaled corticosteroids, approximately 180 intervention patient records have been reviewed, and among those, 67% approximately were on an inhaled corticosteroid that the pulmonologist recommended the patient be taken off of. And 93% of those recommendations were accepted by the patient's primary care provider. So a very high rate of agreement with the e-consult de-implementation recommendations. There have been some challenges that emerged unexpected. Documentation is quite poor. It's oftentimes difficult to understand why patients were put on an inhaled corticosteroid to begin with, and oftentimes patients are put on multiple medications, long-acting agents which are appropriate, and an inhaled corticosteroid instead of starting with a long-acting agent. There are also some differences in interpretation about defining COPD And there's lots of evidence of copying and pasting in the medical record, sometimes with errors being copied and pasted. Here are the results of the lung nodule project. On the middle column there is the pre-intervention appropriateness breakdown, and on the right the post-intervention. And these results were negative. We actually saw an increase in the inappropriate rate, inappropriate follow-up recommendations from 9% at baseline to 23% at follow-up. The incomplete or vague recommendations did decline. That was positive, from 43% at baseline to 34% at follow-up. The study team is currently exploring, trying to understand why the inappropriate rate went up. But one possibility is that the Fleischner criteria changed between the pre-intervention to post-intervention. The Fleischner criteria became more complex and provided more flexibility for the radiologist to change the follow-up period, recommended follow-up period. In terms of mixed methods findings, first, patient reactance. So we had some indication in the baseline interviews for Discuss COPD. The providers were concerned the patients would respond negatively to being taken off of an inhaled corticosteroid. You can see this first quote, but it happens all the time. I've got patients on drugs that I wouldn't have them on, but they insist it works. So unless it's a hazard to the patient, oral inhaled corticosteroids are pretty benign. They're obviously not cheap necessarily, but they also do have side effects, but they're not terrible. So basically the provider's saying, I wouldn't have put the patient on it, but the patient insists it works, so I'm not going to take them off. In the follow-up interviews, we saw some different responses. This provider says, from my experience, I've not had any patients question or want to know more when I explain that there's some concern for increase in pneumonia. They're really receptive. It's partly because I know them well, and for one reason or another, they trust my recommendations. I haven't had any pushback at all. So we see some mixed results there. In the survey to primary care providers, 54% of primary care providers reported, this is in the post-intervention period, that they had proposed discontinuing or reducing an inhaled corticosteroid prescription for at least one of their patients with mild COPD in the previous 6 months. And they also reported that in those cases, when they made that recommendation, that 73% of patients were very receptive or somewhat receptive to discontinuing or reducing the inhaled corticosteroid. Just a handful reported that the patients were unreceptive. One of the key findings from the baseline interviews and surveys was that providers in the Discuss COPD project indicated they were reluctant to take patients off of an inhaled corticosteroid that someone else had prescribed. You can see a couple of quotes here that are emblematic. Generally, on one hand, I'd like to say, in someone who's on a medication they don't need, you should try to stop it. But deep down, there's a little hesitation that if someone is doing well, why rock the boat? If someone came in on an ICS, or if someone sees a pulmonary provider who prescribed it, I would probably be reluctant to stop it. But most likely, I would not initiate it. We followed up with a survey to providers. And this shows you the control providers and intervention providers at baseline and follow-up. And we're in the process of doing statistical analyses, but honestly, the numbers are so small. You can see the N underneath each of the columns that, as our statistician said, just seeing the numbers is probably as informative as any statistical test. But what we do see is that there is a decrease from baseline to follow-up in the providers in the control phase of the study, who say that they are reluctant to take a patient off of an inhaled corticosteroid, and it essentially doesn't change. It ticks up a little bit actually for providers in the control phase. But I think the big takeaway is that it's still well over a third of providers who say that they're unlikely to take a patient off of an inhaled corticosteroid if another provider wrote the prescription. Keeping up with the guidelines was a big issue. Providers were very upfront saying that they found it challenging to keep up with the guidelines, and seeking information about the guidelines in a patient encounter was unrealistic. And these quotes again are emblematic. And this one in particular there was a very frank admission that it was extremely challenging to keep up with the guidelines. I think it's fair to say that I have no idea what the guidelines say. And the second one, again, speaks to the issue of just the practicality of going out and seeking the information. So knowing that the guidelines are out there and knowing that they probably are not up to date on them, it's still not practical to go out, as this provider says, I'm going to prescribe ICS. Let me go read the guidelines about that. You just don't do that. One, you don't have time, and two, you can't necessarily go find that all out. Um, we asked providers about their awareness of the alternatives to inhaled corticosteroids and the harms. This is the proportion of providers who reported that the use of LAMAs and/or LABAs, so that's the long-acting muscarinic agonist or long-acting beta agonist, is as effective as the use of inhaled corticosteroids in reducing risk of COPD exacerbation. And again, blue is providers in the control condition. Green is providers in the intervention condition. And you can see the left is baseline, the right is controls. Control. Excuse me, follow up. And we see a big shift. So at baseline, 42% of intervention providers said that they agreed with the statement or strongly agreed that the use of LAMAs or LABAs is as effective, and it jumped up to 71%, while the providers of the control condition essentially stayed the same. Likewise, in terms of the percentage of providers who reported that the use of inhaled corticosteroids for patients with mild COPD could result in higher risk of pneumonia than the use of LAMAs or LABAs. And you can see the same thing in the control condition. It essentially stayed the same, and it jumped up in the intervention condition from baseline to follow. Now, interestingly, um, we saw a similar pattern in providers reporting that the use of LAMAs and LABAs by patients with mild COPD could result in a higher cardiovascular risk, something that's not true. That is something that was feared but has not been borne out by research evidence. Intervention providers, in spite of the fact that the unsigned proactive e-consult said nothing about LAMAs and LABAs increasing risk of cardiovascular disease, they did appear to jump up. And again, we're in the process of doing statistical analyses, but the numbers are so small that that may not be really that informative, even when we get them. So take this with a grain of salt. Small numbers. The role of specialists in qualitative findings. We saw expressions about the role of pulmonologists that were somewhat conflicting. Um, uh, there was obviously an understanding concern to counter what if a pulmonologist was the one who made a recommendation about a patient being on an inhaled corticosteroid, there was a understandable concern among primary care providers about countering that recommendation. Would I make a recommendation? This is the second quote. Would I make a recommendation for a pulmonary medication to a pulmonologist? Probably not. Yeah, no kidding. But excluding them, it wouldn't matter who they were. We also heard providers talking about the fact that consulting a pulmonologist or making a referral to a pulmonologist for mild COPD was seen as kind of a waste of time, as using up a scarce resource for a condition that was probably viewed as probably not that serious, even though again, as our previous findings showed, um, primary care providers were very willing to own up to the fact that keeping up with those guidelines for COPD was not something that was feasible for them to do. Um, these are some quotes from the surveys. The provider surveys included open text fields, and um, boy, our providers are fantastic. They actually spent some time and wrote some really thoughtful things, and in particular, this first one. And I know this is a lengthy quote, but wow, the provider took some time to really lay down their thoughts, and it's a really considered, thoughtful quote here. So they say many providers use inhaled corticosteroids because it was so difficult to get other long-acting agents such as tiotropium in VA. So this is a problem with essentially with the medication, availability, uh, newer, more expensive drugs. Using evidence-based treatments, the provider continues, even if they are expensive, is important. It has been years now that tiotropium is available to primary care. However, most of the patients who were prescribed inhaled steroids were given these out of desperation when LAVAs and LAMAs were harder to come by. Lastly, it needs to be easier at most VAs to get PFTs, pulmonary function tests. We should be choosing treatment based at least in part on FEV1 and FEV1 slash FVC. David will have to explain that. But the need to return later to the medical center is a barrier. Walk-in PFTs would be really helpful. And this speaks to the issue of just accurately diagnosing COPD to begin with, because one of the big concerns is that, in fact, these patients being treated for COPD when, in fact, what they have is some other condition that's causing the shortness of breath, heart disease, obesity, other things. And in which case, the inhaled corticosteroids and other pulmonary medications are not meeting their needs. So really thoughtful quote here from a provider that they wrote in the. I also wanted to review a few findings from the literature on de-implementation that I think are pertinent to our work and the discussion we'll have on the 22nd. First of all, the literature and research on de-implementation is small currently, but it's growing very fast. The literature on medical overuse and strategies to address medical overuse doubled in a literature review. They found that it doubled from 2014 and 2015, and a subsequent literature review the following year found nearly the same increase. So small number of papers, but they're growing very fast. Same thing in terms of grant funding. NIH and AHRQ grants on de-implementation. There have only been 20 in the whole history of the grant funding process, but half of those have been in the past 2 years. At the same time, physician awareness of choosing wisely, which is 8 years old now, remains stubbornly low. In a nationally representative survey, it was 1 out of 5 in 2014, 1 out of 4 in 2017. First of all, the literature and research on de-implementation is small currently, but it's growing very fast. The literature on medical overuse and strategies to address medical overuse doubled in a literature review. They found that it doubled from 2014 and 2015, and a subsequent literature review the following year found nearly the same increase. So small number of papers, but they're growing very fast. Same thing in terms of grant funding. NIH and AHRQ grants on de-implementation. There have only been 20 in the whole history of the grant funding process, but half of those have been in the past 2 years. At the same time, physician awareness of choosing wisely, which is 8 years old now, remains stubbornly low. In a nationally representative survey, it was 1 out of 5 in 2014, 1 out of 4 in 2017. There's a literature review by Dan Niven and colleagues that found that this literature is very fragmented because of the different terms being used. They found 43 different terms such as disvestment, de-adoption, reversal, and this different language makes it difficult to find articles that are on de-implementation. There have been at least 7 literature reviews or syntheses that have touched on de-implementation and strategies to de-implement medical overuse. Some of these are not formal literature reviews with search methods and inclusion-exclusion criteria. I want to just touch on a few findings that I think are interesting and pertinent. One, again, just to repeat, Dan Niven's scoping review finds just a very fragmented literature, so it's difficult to identify articles on de-implementation. The other interesting thing is that the vast majority of articles that they found on strategies to de-implement medical overuse were focused on facilitating that initial de-implementation. Only 2 of them were on sustaining the de-implementation over time. Scott and colleagues, 2017, did a narrative review on cognitive bias and overuse. This is relevant because they're focused on cognition, just like our model is. So they were looking at different sources of cognitive bias that can lead to overuse and how those might be combated. And one of the interesting things is out of dozens of papers, I think it was a total of 80 some papers that they reviewed, only a small number, 5 of them, were on behavioral nudges, which those are the interventions that are addressed that are targeting automatic cognition. So what we're doing with substitution. So tiny number of those focused on automatic cognition. Vast majority were on reflective cognition. Um, and then finally, Kerry Cole and colleagues did a systematic literature review of interventions to target medical overuse. They divvied them up, divided them by whether they were supply side or demand side, focusing on the providers or the patients. And I'll talk about those in more detail in a moment. Before talking about Cole and colleagues' findings on strategies to de-implement, I wanted to touch on a few findings on drivers of overuse. One, there's this vast literature on geographic variation in care, the stuff of the Dartmouth Atlas. Kehani and colleagues found that that geographic variation is not associated with medical overuse. They also found that models of care, such as managed care, or other capitated systems, including the VA, that we might expect to be associated with lower overuse, actually have no association at all. Another finding is that patients appear to differentiate between overtreatment and overdiagnosis or overtesting. They're very receptive to the idea that overtreatment can lead to harms, but very resistant to the idea that testing, and particularly screening, can lead to harms. And then finally, there is actually a literature about a reluctance to take patients off of prescriptions that other providers have made. So there's some support for our finding that inherited prescriptions, in the case of inhaled corticosteroids, are a barrier to de-implementing them. Going back to Kerry Cola and colleagues' literature review of papers on de-implementation strategies, this is a graph showing the de-implementation interventions that they identified. So this was a review of, they did a review of 108 papers. 84 of them were actually empirical papers on de-implementation strategy effectiveness. And there are a couple of things to take away from this. One, there were 3 interventions that represent the vast majority of both the studies conducted and the studies that found an effective outcome. So clinical decision support, multi-component intervention, so that's an intervention that includes 2 or more of the other interventions here, and then clinician education. Provider education, up there, that's the second from top, is sort of a distant fourth. So 3 of these interventions represent the vast majority of studies thus far. The second thing to note is very few papers have been published that have reported on ineffective or uncertain practices. And it's not in this graph here, but Dr. Cola and colleagues also rated the methodological rigor of the studies, and clinical decision support, clinician education, and multi-component interventions. The average methodological rigor for those published studies was all middling to low, which to me suggests that there's quite possibly some well, one, that the methodological rigor of this literature is middling, and there's the potential for some publication bias here. The second thing, really kind of third thing, taking into account the methodological quality and the concentration of studies on those 3 interventions, it's also interesting to see that they note the majority of intervention studies have focused on de-implementing medication as opposed to labs, tests, other things, procedures as well. I think that's quite interesting, given again, that very limited research evidence, but some evidence that patients are less open to the idea of de-implementing screening, and then the majority of these have been studied in a hospital setting, not in an outpatient setting. There have been a surprising number of models. Dan Niven's systematic review, that's the one that found that there were 43 different terms, at least, for de-implementation, also found that there had been 13 frameworks at that point. This was published in 2015. Ours has come out since then. But at that point, there were at least 13 frameworks that had been applied to the issue of de-implementation. Dan and his team themselves adapted the knowledge to action model, which is a continuous improvement model from implementation. Actually, our own Ian Graham, a member of our strategic advisory board, the strategic advisory group, who is not able to join us unfortunately this meeting, he actually is one of the authors of the knowledge to action model. I'll also point out a few others. Morgan and colleagues have a framework for understanding and reducing overuse that focuses on the culture and sort of systems features of healthcare. Michael Parchman, also a member of our strategic advisory group, proposed a planned action model that's really based on engaging providers at a clinician level in deciding what they're going to tackle in terms of medical overuse, clinical overuse, and how. And then there is one model by Patel and colleagues. These are folks out of the Penn Medicine Nudge Unit. This is a behavioral econ-oriented unit. That's the only model, aside from ours, that I'm aware of that specifically proposes interventions, in this case nudges, that are targeting automatic cognition, that are expressly based on the idea of using people's reflexive heuristics and trying to understand how those can be harnessed to reduce medical overuse. And then, of course, our provider level model on unlearning and substitution. Incidentally, we're not the first or I shouldn't say that, we're not the only ones to have thought about the dual process model of cognition and how it applies to de-implementation. Per Nielsen, a Dutch researcher, in parallel really was thinking about exactly the same thing. And I've reached out, and we absolutely have lots of commonality with Per. If you'd like to, if you're such a glutton for punishment that you want more on this topic, we have a number of presentations and papers that you're free to follow up on and are available online. There's an early webinar that we did on our conceptual model. That's the top bullet. Subsequently, one of our qualitative analysts, Christelle and me, we did a webinar on the Discuss COPD mixed methods findings, the provider survey and provider interview findings, baseline findings. There's, of course, the paper on our conceptual model. And then David Winchester published a paper on the findings from his pilot to de-implement inappropriate myocardial perfusion imaging. So you can read up on those findings if you're curious.